We've got to get back and take over the discussions here and be professional about it. Because it doesn't make sense what I've told you, that you have 1,000 young doctors here for undefined period of time being paid by Pokot. Where's Pokot? For these guys to be here. And where they are, they say we don't even know that these guys are here. So it makes sense. Immediately, let's go to the collegiate system.
Decentralize it.
Yeah. And then MED, let these ones be the last groups. And that is what my task force, when it was still allowed to work, was showing. That yes, 75% of our problems are non-monetary. They're not even legal. It is purely administrative. And we move forward. Six years into my task force, there's nobody who has given us the number of health workers in this country and the number who are in training and the number who are going to graduate next year. None.
How?
Because they don't know.
Safaricom can tell us how many people have M-Pesa, have mobile phones.
Absolutely.
How can we not know?
Absolutely. Because knowing means that you are entering the cartels that in this sector. Those cartels sit in these institutions. They sit in Afya House. Quote me. And this is a kind of thing that we have fostered. How can you be paying people salaries every year and you claim we don't have enough money, but you don't know the numbers? How can you say that you don't have enough money for interns, but you don't know the numbers you are expecting? What are you budgeting on? And then there's something else. Let me tell you this. Internship has also now become another cartel. Traditionally in health, internship was only for doctors. Kenya has turned that one round. First of all, we have only 43 cadres recognized by the government. But the number of health courses
So many.
is over 100. And if you look at some of those degrees they're giving you, you wonder, what is this person going to do? But the parents take them to those colleges believing that mtoto yangu anasoma atakuwa nurse, atakuwa daktari. Some of them as ridiculous as BSc in...
Clinical medicine.
No, paramedics.
There's no BSc in paramedicine.
Yeah, I've looked at it. I've sat with the deans of the 40 schools that train people in health sciences at university level, and I've asked them what's going on. And they've said, sir, we are in a mess. Each one of those trainings, you go and get a member of parliament, draft for him a private member's bill. It is passed. The Ministry of Health, if they're given that bill or to review, they never review it. So it is passed that there will be these people who will be trained here, and at the end of 4 years, they'll get their BSc and 1 year of paid internship by the government. It is written in the bill. So everybody now comes in for 1 year of employment with the government in the name of internship. Yeah. In training in health, there is training that requires internship, there's training that requires some supervision. So what is happening is that the colleges then now get away with practicals. They don't do practicals, they just do theory, because you're going to go for internship for 1 year. So at the end of the graduation, people reach Afya House. Nimetoka hii university hii. And some of these unrecognized cadres even have unions already. Unionism is another cartel now. So the union is there with these guys that here, and the act is this. So why are you denying us internship and salary?
It's by law.
It's by law. That is why you see that mess in the grounds of Afya House. We've created it because we've not taken care of the training system. How many, what it produces, and where you take them. So we think that you get a minister and go and put him in Afya House. He's never been in this sector. And he comes with this magic wand that now I'm Duale or Nakumisha and I'm going to solve this thing. Does he know the history that I've given you? Does he know how med is messing up everybody? Yeah. Leadership is everything. And it is informed leadership. It is honest leadership. Because the biggest challenge for this sector in Africa right now is that combination of knowledge, integrity, and doing it for the public good. Those three things. If we can get that back to this sector, then we'll be delivering more, way, way more than we are. So if you give me one side is that kind of leader, and on this side is a bucket of cash, and you tell me, Khama Rogo, which one do you choose for the sector? I'll take this one any day, because this one here is going down the drain without this. But this one here will make the use of this be accountable. We've lost it.
But we also in a society, a low trust society, if I may call it that, where it's hard to distinguish between the last component you've talked about, leaders that are doing things for public good. So it's really difficult to distinguish when somebody is doing something genuinely for change or that they have their own hidden motives around it. So how do we, as a society, support somebody with good intent?
I think that we have two issues to handle here. One is a professionalism side, that who is a good professional? That one is up to the professional and their colleagues, because as a professional, you belong to this group. The second one is public and ethical. If you look at the countries that have made strides in this sector, you'll see that it is marrying the two. There are, first of all, what is your record before you're giving that post? Because you don't just jump from a medical student to the top. So there's some 20, 30, 40 years of performance that should be put to scrutiny. Do we?
No.
No. You just hear that somebody now is CEC in Busia. What is the criteria for a CEC in Busia?
Probably supporting the governor during campaigns.
Precisely. Now, medicine is like the army. A good army is one that has ranks that are based on a criteria of performance
And merit.
and merit. The moment you mess that one up in the army, you've lost your army. That's exactly what we've done in health in Africa. We've lost that ranking and that respect that comes with the position that you hold and the delivery on that particular position. So that again is a deliberate thing. It is not anything that has not been done elsewhere in the world. That's one. Number two, there must be a performance assessment every year. What did you set out to do in January? What have you achieved by December? This sector doesn't do that. the budget, have you ever seen a county with its annual budget or even the Ministry of Health saying that this is what we're going to deliver this year? This is where we are. No. Never. And why is it that? Because it would show that there's no delivery. That's number one. Number two, that even the budget that's appended to those activities never comes. You cannot run the health sector if you're going to release the budget in May for the financial year that's ending in June. And then you expect that during the last 11 months, things were just okay. And now you're paying your bills in May. It doesn't work out that way. It's not like in education where you can say that teacher so-and-so is coming and is teaching you and will pay the teacher that. Here you are talking about surgery that was supposed to be done on that day. You're talking about a delivery that was supposed to be done in January. You're talking about this cancer where the patient has only 1 month. Otherwise, that thing moves from operable to non-operable. So we got to look at this thing differently. It cannot be just a political game that we play everywhere else.
Then it calls on the professionals to
Absolutely
change the course of...
And that's why I told you that it starts with us, that our house is not in order. We have now gotten into this thing where people claim to be what they are not. People rise because you are closer to power than that you are the person who has a vision to lead us. Where is vision in this? Where is vision when the leadership in Kenyatta says they don't know what 500 university consultants, these are the most highly trained people in this country. They say we don't know what they do. 1,000 medical officer, how many doctors are employed by the government right now?
Was it? I don't remember the number.
I think
but
it's
less
than 300, 3,000.
3,000, yeah. 3,000. If you count the interns, maybe 4,000.
Yeah.
Yeah.
Now, 3,000, 1/3 of them are in one hospital. And you're talking about 47 counties that are supposed to be.
55 million Kenyans
Yes.
plus.
So how can you continuously keep, I haven't added Moi. Yeah. So if you add Moi, then you're really talking of nearly 50% of actively practicing young doctors are sequestered in two hospitals that deny that they know them.
Do other people see it with the same urgency and seriousness that I'm now seeing this?
No, because first of all, they're not serious. I mean, we take health sector to be just something that you say, oh, this year we've employed 20 nurses. No. It is not the output side. It's not the inputs you're looking at. It's the outcomes that are there. If you employ 1,000 nurses, what does that mean in terms of the quality of care that is happening down there? If you take the community health workers and you say we now have this with this budget, what does that mean in terms of the impact on the people that they are meeting with? It's not there. It's a game. And unfortunately, it is a life and death game.
Yeah. You said we are overtraining, underemploying, and exporting human resource, and you gave the example of this area.
Yeah.
So what can we do about that, or what should Kenya do about that?
You see, Kenya has tried sometimes to be what it is not. And this is now wearing my global hat. And let's take it from the point of view of Medical Training College, MTC.
Yeah.
The MTC Kenya is a Nobel Prize undertaking. Kenya should get Nobel Prize for the MTC. Because globally, it is the single most effective, low-cost production of middle-level health workers anywhere in the world, in the history of medicine. Did you people know that? It is something that the outsiders, when they come here, they used to come here and say, my goodness, I wish we had the MTC. That is why you don't have shortages of radiologists, of orthopedic technicians, of all these things. It is because of that creation. And it is only in Kenya. Others have tried to create it, but it is all fragmented. So the medical training and the quality of people from our regional MTC was top class. But you know, we decided to politicize MTC. So from the original 20 colleges, or one college and then to 20, we now have, I think, 87. So every politician, every MP wants an MTC in his area. Have you been to some of them?
Yes.
I have been. They are worse than my local primary school here. And that's a place where you're going to train somebody who's going to decide whether you're alive by sunset today. Simply because we want to have those colors of blue, green, and water at the gate of a place called MTC.
The maroon.
Yes. That's it. So, is that wisdom?
It isn't.
Have you ever seen anywhere there has been serious discussion on just that? Never. Members of parliament are busy voting so that I have an MTC in my constituency. MTCs is no longer even a county issue. It's constituency issue. And some constituencies have two.
Yeah.
But you go there and see what they are calling a training institution for health. They're worse than TVETs. They're worse than TVET.
I've seen
so
some.
What you're asking me, where does that debate take place? Does it take place in the professional journals and meetings? No. And then even if it took place there, where do you take it to the decision makers? Is there a forum for us to sit with members of parliament and tell them, stop this subdivision of MTCs into unmanageable units? That one. So if you look at the number of courses that are done at MTC, and you say that all of these are being diluted, what are you doing to the health sector?
You're producing poor quality workforce.
Now.
And the outcomes will be worse than they are.
Two, the regulator of training, medical council, nursing council, and so on. They're the ones who are supposed to license an institution to be able to train that. That has been taken away from them and left to Commission of Higher Education. So these guys come and say, you can only train 50 doctors. But when you go there, you find that there's 500 because they are getting many fees. Two, and what I'm giving you is facts that I have and that have been placed in front of the task force. Two, indexing. The only professional group that still adheres to some indexing of students is nursing. Indexing is important because you cannot qualify after 6 years if you didn't do the first year. You see what I mean?
Yeah.
So anybody who's going into a medical training ought to be indexed and given that number for life.
From day one.
From day one. So if 6 years later you're now graduating, then should be this same person. Do you know that right now, in the graduation class for MBCHB or whatever it is, there are people who only appear in the graduation list.
Where have they been?
They've never been in part of that. They came to graduate.
And they'll come and treat us?
Yes.
How?
How? Because they've now been given the power to read and write.
That should be criminal.
Yeah, the criminality is what I'm talking about. We are criminal in this country, in this sector.
Because that's somebody you'll entrust with your life.
True.
And they don't even know.
Yes. It is happening. Do investigative journalism. It is there, sitting there. And the resistance to indexing is just that. We don't want the professional regulators in this thing. The University Act gives the Commission of Higher Education the authority to decide you are a medical school, you are a nursing school. It's higher education. So indexing should be inside this. Even our students who go outside in Romania should be indexed. So that by the time they come back, we know that. And these things in a computer, you can see that right now we have 10 students in China. They should be coming back next year, God willing. So our planning then for internship is there. That these are the people that we expect for internship.
If I look at just across the road on Gong Road, Nairobi Hospital is, well, despite its problems, okay, we can go to even Aga Khan. It runs by itself without, you know.
Yes.
So Kenyatta, Moi, and
because
this hospital should be able to be
Kenyatta pays labor. Nairobi uses labor. So they're paid on that side and they come to work here. There's not a single thing that Nairobi Hospital can do that Kenyatta can't do.
Yeah.
Because the skills are there and the equipment is there. Medicine cannot be divided into this is private, this is public. Patients can't be a public patient and a private patient. They are for care. So you give them to best care possible and most affordable. And you do that. The biggest driver of cost in health in Africa is not the private sector. It is the dysfunctionality of the public sector.